welcome you to the podium, and Agnès is going to talk about science, money and politics, the challenge of UHC.
Thank you very much, and thank you, Matt, and thanks to all of you for being here, and also saluting all the people who are watching us on WebEx. I wanted to talk to you today about universal health coverage and the story of science, money, and politics that underpins universal health coverage. And I wanted to start with a painting. It's a painting that is presented in a museum in Paris, and it actually a proof of socialism. And he lived in the 19th century, and he's here in his garden in Paris. And as you can see from the painting, he's kind of a well-off man, right? He's a bourgeois, educated, writing books, reading a lot of books. You see it on the painting, having a very nice house in the in the wealthy suburb of Paris with a garden, and he has his children next to him, two little daughters. But what we don't see in the picture is the youngest one, the cute one who is playing on the ground, actually died in infancy, and she died of cholera. And I really wanted to start like that in fact, less than 150 years ago, a little bit more than 100 years ago, we were all, as a global human community, we were facing a similar fate, a fate of a very high child mortality, and losing a child was a universal experience. Almost every family was actually living through this very emotionally difficult tragedy, and it was. And when we think about how we have moved from this time in a little bit more than a century, we have really escaped what was the historical fate of human beings over all of human history. Tens of thousands of years of human history that were living that fate of very high child of mortality, 30%, 40%, half, depending on the context, of children dying before the age of 5. And it was independent of the economic status or education. At the very same time, it was really recognized that ill health was very strongly associated with poverty. Here is another painting, again a painting of the same period in history, 19th century Europe, in which you see how tuberculosis and other chronic disease, infectious disease, were intimately related to poverty and destitution. And you see how here in this bedroom you see this very young women dying of tuberculosis in a household who obviously is plagued by poverty. Is it poverty that led to tuberculosis? Is this tuberculosis that led to poverty? The painting doesn't say, but we know that it was and it still is an intimate relationship. Tuberculosis was affecting the cities of Europe in the 19th century so much that it was called the White Plague. So all of this to say that the sort of good health that many of us in developed economies and in the richer, wealthier groups in the less developed economies enjoy, and the long life expectancies, is something actually very recent in human history. And that is really what has been the incredible revolution of the 20th century that is also been associated with an unprecedented increase in the population on the planet, together with an increase in economic growth. So that's really a story of health and wealth. So where are we today? If we start looking at the science, so the science has helped us escaping, and that was the word coined by the Nobel Prize Angus Deaton, who actually looked at that, to look at how through technology, health technology, asepsia, antibiotics, vaccines, effective medicines, but also through improvements in welfare, we have escaped that fate that was ours for tens of thousands of years. So if we go to the WHO website, the Global Health Observatory, so here's, I'm going there together with you, and we're clicking on the website, and I go to the section, which is the section on universal coverage here, and we try to look at what does science tell us today about where are we when it comes to our access to this incredible technology that has changed our human fate. So here is a map of the world, and this map is showing an average coverage for selected health services. It's a group of indicators selected, different maternal and child health, communicable disease, non-communicable disease, etc. And we aggregate them into an index, and we look at the coverage of health services around the world. So this is where we were in 2000, and you see the darker the color, the higher the coverage. You see high coverage in North America, Western Europe, and Australia, New Zealand, somewhat also Brazil, and a few other countries. Africa clearly showing a lower level of coverage. Now, what has happened over the past 15 years? When you see that, in fact, you see the map is getting greener and greener, and you see that increasingly the whole of Latin America, the whole of Europe, including Central Europe and Eastern Europe, the whole of Asia has actually improved its performance on delivering services, essential services to people. And also some countries in Africa, particularly North Africa and South Africa. We're still, some countries lagging behind, particularly in sub-Saharan Africa. But to say that this progress is still happening. We are still in a phase of human progress when it comes to healthcare. We have improvement in, as WHO last year, we came up with about half of the world having access to healthcare. So yes, it's still insufficient. It's still a lot of work to get to universal access, but we are on a path of progress. What do we know? So let's take what is the main input, which are health workers, which in most countries represents about half or even more, 60%, sometimes 70% of the expenditures on healthcare, particularly the recurrent expenditures. We know that more health workers contribute to a higher level of essential health services coverage. That's a fact. You see that the more health workers, the higher the coverage. But you also see that at some point, really, you may have the same level of coverage with different levels of health workers. And actually, we have quite some evidence here very clearly that it doesn't necessarily mean more equality in access to health services. It's not just by multiplying the number of health workers, it's not only by increasing the supply side of services that you actually get more access to services. You still have issues of inequalities of distribution that plague our progress on universal health coverage. So not only a supply side problem. What we know, and you've discussed that previously in this course, is that more government spending is also important, very important. Public spending is key, And it is associated with better coverage of health services. But you see, that relationship is actually kind of efficiency matter. At the same level of spending, you can have vastly different results. The same level of public spending. And at the same level of results, you can have vastly different levels of public spending. So public spending is very important. It is essential. But you've discussed over the past 2 days that what it is that public spending buys and how public spending is organized also matters. Now, what does happen when governments spend more on health? And typically, we always think that if government spend more money on health, then people will spend less. That there is a kind of automatic relationship. Government spends more will lead to less out-of-pocket spending and less catastrophic expenditure, less impact on the poor. So it's a kind of assumption. So let's look at this set of data, again, between 2000 and 2015, and look at 3 countries. So if we look at the first country, that's this big circle in yellow at the top left, and we're going to follow that country over time. You see, this is where you have the little arrow. So you see that over time, this is really a country that is making a lot of progress. It spends more and more on health in terms of public spending. And at the same time, you see a decline in out-of-pocket spending. So this is the ideal. This is what we want to see. Government spends more, out-of-pocket spending and impoverishing spending declines. However, unfortunately, that relationship is not always there. So if we look at the second country, and here my little arrow is changing, it's going to that green circle, again top left, and we follow this second country over the same number of years. So follow the little arrow. And you see the country is increasing its public spending a little bit, and then it's decreasing, and then it basically stays where it is. Over the whole period, out-of-pocket spending. So there are also cases in which you see that the country is not really moving, or is moving a bit in increasing public spending, but it doesn't have an effect on out-of-pocket spending. Third case, and here look at the little arrow in blue, which is that country in the middle. It's a country that has some reasonable level of out-of-pocket spending, and it's sort of in the middle of the range in terms of public spending. Look at what happened in that country between 2000 and 2015. You see, in fact, you see that the level of spending is slightly declining publicly, but unfortunately, out-of-pocket spending is increasing. So you see that over time, it's really important to be able to look at what is happening in a country, because there is no automatic relationship between economic growth, public spending, and out-of-pocket spending. It's all extremely dependent on policy, which is also dependent on politics. And I'll come back to that political message. So what we see here, and it's the relationship between out-of-pocket spending and financial hardship, you see that the countries in blue are high income, the countries in red are low income, and in the middle they are the middle income, the low middle income and the upper middle income. You will see that at all levels of incomes, you have countries who have financial hardship. So you see the blue ones, the high income, for a certain level of out-of-pocket spending, some countries have a much higher level of impoverishing expenditures and catastrophic expenditures, which means that it's not all about income. You can be in a very high income country and still have expenditures leading to poverty. Because you don't have the right policies, the right safety nets, the right insurance, the right pooling, protecting people. The problem of financial protection and protecting people from the impoverishing effect of spending out of pocket on health is not an income issue.
it is a policy issue.
I think so.
So, how does money play a role in driving the results that we are expecting is nonetheless a critical issue. So, how much do we think it's going to cost to reach universal coverage? So that's a question that we asked ourselves at WHO, and we actually run some models. So here, caveat, it's a model, right? So it's a model, it has assumptions, it doesn't say that it is what is going to happen. But we actually looked at different experiences. We have cost data from different countries, we have coverage data from different countries, and we try to model and to have a sense of how much it will cost to move to about slightly less than half of the population in the world having access to health services to actually reaching universal health coverage. And we started from this starting point of the Commission of Investment in Health 2035, which says that this escape that we have observed in the 20th century about the rich world and the rich groups in the poor world having escaped the human fate of high mortality and short life expectancy is actually a fate that now can be enjoyed by the entire population, global population. This is what we call the grand convergence. That is, it's no longer an escape, but it is a convergence. That is very likely the whole developing world is going to join the curve, and everybody can enjoy long life expectancy, and all countries can reduce child mortality to the point that the death of a child is going to become exceptional around the world, as it is already in the developed world and among the richer groups in the developing world. So clearly, technically, this grand convergence is achievable. That's what the science says, and we think that all countries could reach the level of low middle-income countries today. It could reach a child mortality of around 15 per thousand, and also reduce mortality of all the infectious, the communicable disease, including HIV and tuberculosis and malaria, as well as curtailing the epidemic of non-communicable disease, particularly through health promotion programs and measures. What would this do? According to this model, this would actually lead to avoiding 97 million premature deaths by 2030. So life saved, 97 million. This would actually mean investing about 3.9 trillion over the next 15 years, which basically by 2030 would be about 300 billion for the world, which is, think about it, 300 billion or 3.9 trillion is actually much less than what we are spending today. And I'll come back to that. And that is about what would we need to scale up. This would be about 36% would be investing in human resources for health, and about 34% in infrastructure. So the big cost items is investing in people and investing in capital. Right? And then there is some money also that needs to go in support systems, institutions, as well as in medicines. But the two big ticket items that go up to 70% of the price tag is people, pre-service training and compensation, as well as infrastructure, expanding services, particularly infrastructure such as water, electricity, and connectivity in facilities to provide services to hard-to-reach populations. So this will actually mean that these services will be delivered through different service delivery platforms, which include hospitals, of course, primary healthcare clinics, but also outreach, mobile strategies when it's needed, or campaigns, as well as community health and policy measures, public health measures that will affect the behavior of people, and particularly with an emphasis on the fiscal incentives, which are tax and subsidies, and one of them are the health taxes, the taxes on tobacco, alcohol, sweetened beverages, and sugar, and other, for example, the taxes on fossil fuels, removing subsidies on fossil fuels, maybe shifting to taxes on fossil fuels is an important part of this equation. What would be the financing gap? If we look at what countries would be able to finance, and we take here some reasonable assumptions of what would be patterns of economic growth and associated patterns of revenue generation, fiscal expansion through increased taxation, as well as reasonable assumptions about how much would be allocated to health, we find that actually the gap is at a level that is manageable if we think about how much is spent today in terms of global health spending, which is about 54 billion a year. Because if we compare this 54 billion a year, that would be the financing gap, to actually what we're spending on health today. Today, we spend about 10% of the global GDP on health. That is about 7.3 trillion. So if you compare this 54 billion to the 7.3 trillion, you see that there is a very large difference in the order of magnitude. And what we know is today, and we observed that over the past 15 years, is health expenditure grew much faster than the economy. You probably often heard that over the past 15 years, global funding from development assistance for health has multiplied by 5. What you probably have heard much less is over the same period, domestic financing in low and middle income countries has increased by 6. And that the increase in health expenditures in low and middle income countries has been 6% per annum, 6% per year, while the overall economy has grown by 4%. Which means that today, I mean in 2015, for which we have very good data, we estimate that the spending on health in low and middle income countries is around 1.6 trillion. That's 1,600 billion to compare to the 54 billion. So you see that we are moving into a world in which, in fact, the spending on health is accelerating because of a combination of economic growth, of better taxation, and increased willingness of people, citizens, to choose health as a main area in which they want themselves to spend as household, but also they want governments to spend, and they want as citizens to influence these governments to spend on health. So what we observe, and that's again the data that we at WHO published recently, last December, and the report is available here for consultation as well as on the web, is that domestic public finance is growing, and it will be the most important and the key funding mechanism to achieve universal health coverage. And we see that domestic finance has been increasing in all the groups, all the economic groups. It has been increasing in OECD countries, in the high-income countries. It's been increasing in the middle-income countries, the upper middle income, the emerging economies, China, India, Indonesia. It's been increasing in the low middle-income countries, Kenya, Ghana. It's been also increasing in some low middle-income countries. However, on average, in the low middle-income countries, in the low-income countries, we find a very disturbing pattern, which is actually it has decreased. Domestic funding has decreased in a number of countries. So here you see that in the red, you see the increase in external financing in these low-income countries, and in blue, you see the domestic financing which has declined. So what we've been observing is a very significant and large effect of fungibility of external financing. And it's not that we didn't know that there was fungibility. Fungibility is a very well-known phenomenon, it's been very well documented. But at the same, very few of us had expected that we would find that on a very large scaling in so many countries on a systematic basis. So really here we have an issue which is to think about how are we going to manage development assistance for health in the future and try to get out of this trap of fungibility. How can we be smarter in the way we use development assistance for health so it doesn't have this offsetting effect of basically displacing domestic financing and treasuries and ministries of finance basically to decide that, oh well, if there is external money here to fund health, I may just as well use my own domestic funding to fund other sectors. Water, transport, energy, defense. It may not always be a bad thing for health. It's good to fund water or agriculture for health. Sometimes it may not be such a good thing if it's spent in too much in defense or if it's going to unproductive expenditures. But the fact is that just pushing development and health assistance into health programs might actually have the opposite effect than actually increasing domestic financing. And we need to be smarter in the future about addressing this problem. In fact, what we see, and I come back to this order of magnitude issue, we see that there is more and more evidence that the role of development assistance in health is going to decline in a big way. Already in 2015, 3 years ago, and it's probably has gotten even more clearer today, is you see that the development assistance for health that we find at country level using national health accounts is less than 20 billion. Let's say it's about 19.2 billion, let's say around 20 billion. While as you can see, the overall spending is 77.3 and the public spending is 4.4. So when we look at countries by economic level, you see that in upper middle income countries, the development assistance for health represents less than 1%. In lower middle income countries, less than 3%. And it's only in about 30 countries, 30 low income countries, that development assistance for health represents still a sizable and important part of the funding of the health envelope at around 30%. So what do we say in this case? Still using our model. If we use our model and we look at how much it costs to fund universal health coverage, we see that 85% of this cost could be funded through domestic funding, and there would be a need for investments of 15%, mostly in these 30 countries, and mostly for infrastructure and human resources, as well as associated investments. But here we're really talking about increasing the health workforce as well as ensuring the foundations of health system, making sure that the input markets work so that the systems can evolve and start delivering more services, sort of fixing the supply side. So to conclude, if reaching universal health coverage and reaching the convergence in which
every individual, every human in the planet, every child in the planet would enjoy the same kind of access to health care and quality of life and long life expectancy that citizens of high income and increasingly upper middle income countries enjoy, if it is possible technically, and if it is possible financially, that we actually are finding that it is largely possible financially, what are we left with? Well, as you know, we're left with politics. Because we've seen that the relationship between money and results is actually kind of loose. It's not all about more money. And if we look at politics, I want to sort of go back to this relationship between economy and health spending. You remember when we looked at results and public spending, we saw that there could be a very large difference between countries. It's not all about more public money will get more results. So here the relationship was kind of loose. Well, there is another relationship that is not loose at all. It's actually a very, very strong relationship. It's the relationship between economic growth and overall health spending. Which means, and you see, it's almost a perfect correlation, right, with a very strong R square. The fact is, when countries grow, they spend more and more on healthcare, not only because the pie grows, but also because the slice grows. That when a country gets richer, it has more public revenue. So public revenue in a very poor country is at around 10, and then it will move at 15, and then it will move at 20, and then it would move at 30, 35. And sometimes in high-income countries, it can reach 57. So you would have the taxation will grow. So there is an exponential effect of growth on taxation. And then you have another exponential effect, which as countries get richer, citizens usually choose to spend more on health. So you start seeing the share of health in the budget increasing. So you have another potential exponential effect. So what we know, and that is a very different message from the message we had 15 years ago, is probably there will be more money in healthcare, just by the effect of economic growth, taxation, and increasing choices of citizens to prioritize health in budgets. And what is also increasingly documented and is kind of new is the fact that investing in health services is actually an investment, not a cost. And that's quite new because until recently, investing in health services was considered a drag on the economy. Right? It was to say like, well, I need to first grow my economy and then I can spend on social services. And it was seen as a drag on the economy because it was seen as a sector in which productivity gains were slow. Well, you see how quickly you have productivity gains, for example, in the telephone industry, in the communication industry. You know that if you look at a smartphone today, and you look at the components in the smartphone, that smartphone 30 years ago have cost more than $1 million. Now it costs a few hundred. That's major gains in productivity. We haven't seen this kind of productivity gains in health. One of the reasons is it's a sector that is heavily reliant on labor. So typically what the studies show is when you invest more on health, and particularly when you have it documented, that you have escalation of cost, and that escalation of cost was actually playing a negative role on economic growth. So that would be the kind of knowledge that economists and people working in finance, in ministries of finance, would have as a received model that investing in health is actually a dead weight on the economy. Well, guess what? This is really changing. And this is changing for a different set of reasons. One is because of technology, because of more effective use of those technology, because also of overall change in the economy with robotization and automation, the fact that we are now thinking about the fourth industrial revolution in which the nature of industrial jobs will change. It seems there is a shift in the economy, and now the latest study we've done with some colleagues in the University of Geneva, the Graduate Institute for International and Development Studies, is we find actually using a macro model, using real data in low and middle income countries, but also in OECD countries, that we increasingly see a positive effect of investments in health services on economic growth. And right now, the model, which will be published very soon, shows that there might be a gain in GDP of the order of 2.4% by investing in universal health coverage of 2.4% over a period of 5 years. So that positive effect is very new. And we see that increasingly that we're talking about the health economy. And that's been coined in a study here that I'm showing in Germany, which is there is already an economic effect of just outputs, service outputs, outputs of the pharmaceutical production, outputs of the technology production, outputs of the device production. But there is also an impact of the health services on the productivity of other sectors. And altogether, this share of the economy that goes to health, which is currently globally 10%, but as you know, reaches 19% in the US, is actually an economic driver, not an economic burden. So that really plays completely differently on the politics, because now we see the health sector not only as a sector that improves human development and well-being, but also as a sector of the economy that actually can drive economic benefits and economic outputs, and can be seen, you can see investment in healthcare as an economic strategy that creates jobs and creates economic growth. Actually, if we look at what is happening right now, and this is work that we've been doing together with the World Bank as a background to the Commission on Health, Employment and Economic Growth, we see actually that the health sector is going to be one of the key sectors of employment over the decades to come. There is a study in Nordic countries that shows that if we keep the same healthcare model that we have today, and particularly with the emergence of the aging issues and the non-communicable disease epidemic, there would be the need to employ about a third of the workforce into healthcare. So the employment and the number of jobs that are created in healthcare outpaces any other sector. In our projections, you can see here, so there are 4 groups of countries: low income, low middle income, upper middle income, and high income. And you see, in red is the needs for health workers. In green is the supply, and in blue is the demand. And actually what you see, which we see more and more, is in fact that we have increasingly a demand that is outpacing the supply. It's not a matter of needs. It's a matter that, in fact, we have a true shortage. We have more demand for health workers than we are capable of producing health workers. And you see it, you observe it, you see that now all countries, there are probably less than 5 countries who produce enough health workers. And the market for health workers has become global. The high-income countries are looking for health workers because we are estimating that there will be a demand for 40 million. So there will be a market demand, there will be jobs for 40 million health workers. We're not producing those. So there is only in low-income countries in which there's still a problem of demand, there is a problem of money, that needs to be addressed partially through better use of domestic funding and smart use of development assistance for health. But the fact that already, even in the low middle income countries, there are more jobs for health workers than there are health workers. So we really have a supply problem, and one of the areas that we will need to address in our political discourse is the need to invest in skills, in training of health workers, so that they can fill those jobs that are opening. So let me finish and conclude with with the last point on politics, and that's really coming back to what we've been observing of the fungibility effect, that when you push development assistance for health on low-income countries that may have institutional constraints, that may have political constraints, governance constraints, then we start seeing that governments actually withdraw domestic funding. And a key problem, and that's a graph that we presented in the World Development Report 04, is that you have two routes for funding healthcare. If you are people, you can fund it through the market. That's the short route, so you pay directly the provider. Or you can pay taxes and empower your politicians as a government to provide healthcare, and then it's the government with the public money that instructs providers to provide services. And most countries all countries use the collective funding to fund providers to serve their people. So this is what we call the triangle of accountability, in which poor people are the principals. They are acting as clients of services, like they are giving money to providers when they need services, but they are also citizens. And they give taxes, they pay taxes to government, and they instruct the government about their choices so that there is collective financing of health. And that's the triangle on the right. The issue we have right now in global health is that there is another triangle on the left, which is the donor triangle, in which we have another set of actors, and we have other principles. It's not only the citizens of poor countries, but it's also the citizens of rich countries as taxpayers who are paying taxes in the rich countries, some of these taxes being used for international financing of international institutions, financing the UN system, financing the global institutional system, and financing aid agencies. And governments in low-income countries receive funds, or sometimes providers receive funds. For example, when NGOs come directly to the country and give money directly to clinics, and sometimes poor people receive funds, and sometimes there are cash transfers that are given directly by the donors to the people. So you have the triangle of accountability of donor countries interfering with the triangle of accountability of the poor countries. So the citizens in the poor countries are no longer the sole principals. There are citizens in other countries that are also making choices for them, and they're making choices through aid agencies. And of course, the tension is that these two groups of citizens are not at the same level of information. Those in the donor country don't necessarily have the information of the citizen in the recipient countries, and their interests are not necessarily aligned. And that we see increasingly as a tension that we also need to address when it comes to funding the gap to reach universal health coverage, is how can we better align the vision and the interest of people in poor countries and people in rich countries. And some of the way to align their interest is actually tackling the common problems, the problems of common goods, of public goods, such as environmental issues, climate change, cross-border issues, pandemics. And we see that these issues are increasingly coming to the forefront because they are issues that we need to resolve collectively. We cannot resolve the climate change or the ocean acidification issue or the flu pandemic issue just one country at a time. All citizens in all countries need to be somewhat the actors of this kind of collective action. So increasingly, we face that problem of collective action that is not only, already we have a problem of collective action at country level, and you all know how difficult it is to bring all citizens towards one vision in a given country, but we also have a larger collective problem, which is aligning the interest of citizens both in the high-income countries, in the low-income countries, and also tackling the common problems that we all face that are
the global public good. So that's increasingly going to be at the heart of how we will be able or not to tackle the big challenges, not only the challenge of universal health coverage, but sort of bigger challenges such as the threats on human health that are driven by environmental change and climate change. So one aspect that I wanted to finish on a kind of note is that if we want to align the interest of people at country level as well as at global level, then one key element is that these people are empowered and are able to influence policies. And one of the challenges that we have right now is something like freedom of information is actually going backwards. So some core element of that triangle of accountability, the fact that people can voice their view. They can voice their views through the vote, they can voice their views through the public debate, they can express their views and opinion, is actually over the past 5 years, you actually have a decline in freedom of information in the world that is signaled by several agencies that are measuring this, including Freedom House. So that's also something that we as a community working on universal health coverage need to be aware of, that this is something that we need to invest in societal dialogue in Tunisia, in national health assemblies, invest in having people being able to express their voice towards that social contract that is universal health coverage. So what do we do? Clearly, and that will be my last word, is we need to be aware that more money will come to health. It's going to happen. The question is how and for what. Will it be money that will be private, that will be impoverishing? Will it be for high inefficient technology? Will it be for systems that will be highly inequitable? You have already today, you have countries that spend a lot of money and still they don't have universal health coverage. There will be more of these countries. There will be more countries in which you will have a system that will have a lot of money, but not necessarily equity. So the question will be how to develop pooling systems. The question will be how do we use the public purse well to purchase services. And for that, reaching universal health coverage will require politics. With the politics in the sense of collective action, accountability, people being able to voice their preferences, and this will require investing in that political process, investing in creating the platforms for citizens to voice their preferences when it comes to how public money will be used for healthcare. And that people agency is really the key. People, we know health is not produced by hospitals. Health is produced by people. And people are producing health, they are producers, they are users of health service, but we often forget that they are also citizens. They are the ones who also decide on the public purse. They decide on the private purse, they decide on the public purse. So people are the key of the success on universal health coverage. Thank you very much.
Thank you very much, Agnès. Fascinating overview of the broader issues related to UHC, the politics and the money and so on. So thank you very much for that. We can take, before we invite our second speaker, we can take a few quick questions from the audience. We will have a more open session at the end. But if there's a couple of quick questions now, we can take those. Yeah, Joe, there's one over there. Okay.
Thank you very much. Very interesting and informative. My question is about the HR. That you rightly mentioned about investments in educating of HRH. But what is happening in some countries? They are planning for increasing number of HR, but due to political situation, then people, they are migrated to the other countries. So particularly for Iran, I'm talking about Iran. In Iran now, due to this clash, due to this problems between Iran with US, and day by day talking of Mr. President Trump about Iran, people they become more disappointed. They wanted to get rid of this political situation, and particularly for HR in health, they wanted to go out. So we are planning, we are investing in health, but when in application, people, this is their choice. They wanted to get out. They don't want to involve in this, clashing situation. So
Thanks.
how you see this?
Thank you. Yeah, maybe we can just take one more, and then we could, Alexa here, and then we'll ask Agnès to give a quick response, and then we'll move on.
So very briefly, so this is when you were discussing about the impact of health on economic growth, it's actually very relevant to the country I live in India, because largely health is being perceived as an expense, not actually as an investment. So what does the literature say about, what mechanisms, what are the pathways by which investing in health actually results in economic growth?
Agnès, would you like to give you can either use as you like.
Actually, yes, I will start with the last question, because I know the screen is not very good at least it's not very compatible with my slides. So there are different pathways to economic growth, right? But let's see, there is an economic simple answer. It is through labor and capital. So it's affecting labor, the productivity of labor, and it's affecting the investment in capital. But if I'm trying to be more specific on what it means, first it goes through basically just economic output. When you have a pharmaceutical industry that produces medicine and they sell them, it's an industry. It's like selling shoes. Right? So it just counts. It is counted in the GDP. And it's the same if you deliver a service, if you do a CAT scan, it's counted in the GDP. So you have a mechanic effect, almost, right, of economic output. But you have more than that. And one part is going through the health, like better health, as actually affects the quality of labor. On the capital, it's like you have investments in health, in healthcare, that actually improve the investment in infrastructure. And that one of the reasons where probably the coefficients are changing is the information technology, the IT, how it affects healthcare. And all the investments there in information and technology and information system. So that's another pathway. You have a social protection pathway. So that plays into what we call Pareto efficiency. It's like because health has an insurance function, it protects people from losing assets. It protects people from falling into poverty. So it actually protects their consumption. Right? So it's the safety net effect of health, which also plays into economic growth. And then you have three others which are actually very important. One is health security. So we've seen it in this, for economists, the Ebola epidemic has been a gift. We've always said that an epidemic would have economic consequences. Well, in Ebola, we know it's not a model. It's real, actual measurement of the effect of the Ebola epidemic on West Africa. The results is very, very clear. It affects economic growth in a big way. The GDP, the income of these countries has declined after Ebola. We also have evidence from China on SARS, that you see a dent in the China economic growth that is due to SARS. And then there is, of course, the technological changes. Interestingly, if you look at all the technological drive that affect productivity generally of economies, a lot of them are in healthcare. Right? And then finally, and I'm really emphasizing this one because it really matters to countries that are fragile, is universal health coverage is a social contract. It contributes to social stability. Actually, historically, not everybody knows that. When universal health coverage was started in Germany by Bismarck, famously, who was the chancellor, the prime minister of Prussia, it was introduced as a way to fight revolution and fight socialism. It was a way to do something for the workers so that they would not shift, and start questioning the power in place. So universal health coverage as a social contract, social cohesion, and one of the things that we're saying as WHO is universal health coverage should really be seen as one of the elements, for example, of a state building. And so instead of saying we need to invest in state building so we can have services, no. Is universal health coverage is part of it, it's part of state building. It's also part of a strategy to reduce migration, for example. We know that a lot, it's in the news every day, people are very worried about migration. When you look at who migrates, most of migration is because of conflict, not because of the economy. Right now, the migration to Europe is mostly Syria, Eritrea. These are people who leave, or Somalia, these people who leave conflicts. You think that if you could invest in social cohesion, that would be a pathway. So all of these are the pathways. But what is really exciting for us, particularly as health economists, is typically we had what we call the Baumol effect, which was this idea that the health sector was typically its productivity gain were always lagging, so it was dragging the economy. Now we have actual empirical evidence that it's no longer true. And it's no longer true because the economy has changed and because the health sector has changed. And also there are different, probably also because the demographic composition has changed, right? It's that we are in an aging society. So because of all these changes together, now we start finding that in fact, it's a growth, that investing in health services is growth inducing. This doesn't say that we can do anything. It's probably because we've been more efficient. And certainly what we finance in healthcare today is probably much more effective on health than what we used to finance 50 years ago. People tend to forget, again, that when universal health coverage started, so Germany, let's put it in the end of 19th century, there was no antibiotics, there was no asepsia, there was no vaccine. This was not a health strategy. It was a social protection, social cohesion strategy. And obviously, the productivity of health services at the end of the 19th century is uncomparable to the productivity of services today. It's like a different industry. So the question on human resources, I think, is the problem that you are signaling coming from Iran. The problem is, as I said, there are probably less than 5 countries who produce enough health workers today. So we have a global shortage. So now what you have is basically money chasing health workers around the world. And so the whole idea that there is something else to do than training health workers doesn't stand any scrutiny. And a key reason is, again, because health was one of the rare sectors in which the production of health workers was controlled by the state through barriers to entry, either because only public universities could train health workers or public services, or because there is a number that is restricted. We have that in Europe. It's called numerus clausus, in which the state decides how many health workers will be trained. The problem is the state has been wrong in the projections. But the state doesn't decide how many plumbers, how many IT specialists, why is the state deciding how many health workers? It's just coming from a tradition of central planning, but the state doesn't decide about the other professions. So because of that, the market forces have not played, and now we are in a stage of shortage. When you have shortage, you have migration, countries are competing for the same health worker, and you have wage inflation. What we see, wage compensation of health workers is going up everywhere in the world. The only way to address that is start training more. And what all our work shows is just the demand is much higher than the supply. So we need to invest in the supply.
Great. Thanks, Agnès.